Hello everyone, I'm Dr. Alaa Mosbah, Professor of Obstetrics in the Gynecology Faculty of Medicine, Mansoura University. The topic of my lecture today about acute fatty liver of pregnancy. So, what are the objectives? The definition of acute fatty liver of pregnancy, epidemiology, etiology, diagnosis, complications, treatment, and lastly, the prognosis. Okay, so what is acute fatty liver of pregnancy? This is an obstetric emergency characterized by acute liver dysfunction due to fatty infiltration of liver parenchyma, which can precipitate coagulopathy, electrolyte imbalance, and multi-organ failure that can lead to maternal and fetal mortality. So, as you see, this is an obstetric emergency. It is not very common, but it is very dangerous for the mother and the fetus. Here, the problem here, there is a problem in fat metabolism. There is fatty infiltration in the liver parenchyma, damage to the hepatocyte. This damage of hepatocyte may end in multi-organ failure and maternal and fetal mortality. So, it is an important complication that may happen during pregnancy. Okay, what about the epidemiology? So, acute fatty liver of pregnancy affect 1 in 7,000 to 20,000 pregnancies. And you should know that acute fatty liver of pregnancy is the most common cause of acute liver failure during the pregnancy. So, if we are going to say which is common during pregnancy as regard the liver disorder, we can divide them. If we are talking about pregnancy-induced liver disorder, intrahepatic cholestasis is the commonest. If we are talking about the commonest cause of jaundice with pregnancy, viral hepatitis is the commonest. If we are talking about the commonest cause of acute liver failure during pregnancy, then we are talking about acute fatty liver of pregnancy. Okay? Okay. So, what else in epidemiology? When it occurs during pregnancy, usually in third trimester, in late pregnancy, between 30 to 38 weeks gestational age. So, it is a disease or complication that happen in third trimester of pregnancy. What are the risk factors? The most important risk factor is that the fetus has an abnormality in certain enzyme related to fat metabolism. What is this enzyme? Long-chain 3-hydroxyacyl coenzyme dehydrogenase deficiency. Other risk factors including history of acute fatty liver of pregnancy in the previous pregnancy, multiple gestation like twins, triplet, and so on, presence of HELLP syndrome and preeclampsia, and it was found that male fetus is a risk factor. Okay? What about etiology? Really, the problem in acute fatty liver of pregnancy is related to defect in fatty acid metabolism. As you know, during a pregnancy, especially in the third trimester, there is increase in free fatty acid to support fetal-placental growth. So, in presence of defect related to metabolism of these fatty acids, they accumulate in hepatocytes and cause cellular damage. So, the pathogenesis of acute fatty liver of pregnancy has been linked to the enzyme deficiency. What is this enzyme deficiency? Enzyme related to fatty acid metabolism, which is called long-chain 3-hydroxyacyl acyl coenzyme dehydrogenase. There is deficiency in this enzyme. Okay? And you should know that this enzyme is deficient in the fetus and in the mother. And the mother is heterozygous for long chain 3-hydroxyacyl coenzyme dehydrogenase deficiency. She is heterozygous. And the baby has deficiency in this enzyme. This leads to effective beta oxidation of the fatty acid in the fetal mitochondria. But why this happen in heterozygous mother and the fetus with deficient long chain 3-hydroxyacyl dehydrogenase, it is still unclear. Okay, but you should understand the idea. The idea there is defect in metabolism of fatty acids leads to accumulation of this fatty acid inside the hepatic cell, causing damage to the hepatocyte. Okay? Okay. So there is gene mutation, homozygous G1528C mutation appear to be the most commonly associated with acute fatty liver of pregnancy. But any gene related to enzyme needed for metabolism of free fatty acid and this enzyme is deficient can lead to also acute fatty liver of pregnancy. So this is not only the only enzyme. Okay, there may be other deficient enzyme related to fatty acid metabolism and they can causing also acute fatty liver of pregnancy, but the commonest up till now is related to homozygous G1528C mutation. So what about the diagnosis? How to reach the diagnosis of acute fatty liver of pregnancy? As I said before, presentation of this complication happen in third trimester, mostly. Starting with symptoms like nausea, vomiting, abdominal pain, anorexia. Also, some women may present with hypertension, proteinuria, usually as a consequence of concurrent HELP syndrome or preeclampsia. Okay? By the way, differentiation between acute fatty liver of pregnancy and HELP syndrome is a challenge. Okay? Okay. Then what will happen? Acute liver failure may develop rapidly and characterized by jaundice, ascites, coagulation disorder, phallopathy, confusion, and multi-organ failure. So we should think about acute fatty liver of pregnancy after exclusion of other causes of liver dysfunction like fulminant viral hepatitis, drug-induced liver dysfunction, and the acetaminophen poisoning. All of this should be ruled out. During physical examination, you may notice the jaundice, of course, confusion of the patient, abdominal tenderness. What about lab finding? Complete blood count showing low platelet and the elevated white blood cell count. Coagulopathy. There is increase in INR and the prothrombin time, decrease in fibrinogen. What about liver function test? Serum bilirubin increased, liver enzymes increased. Also, there may be renal insult with elevated serum creatinine, elevated ammonia, urine protein assessment is important. Blood glucose, the possibility to be hypoglycemia. It is characteristic of acute fatty liver of pregnancy, hypoglycemia. What about radiological examinations? Ultrasound examination of the liver may be non-specific or may reveal fatty infiltration in some cases. MRI also may reveal fatty infiltration in the liver. Should I do liver biopsy to reach the diagnosis? Really, it is rarely indicated. You can diagnose acute fatty liver of pregnancy without liver biopsy. But in the past, they used to do, in some cases, liver biopsy to reach the diagnosis. Okay? The problem with liver biopsy, we have here coagulation disorder, so it is dangerous. So it is not advised to do liver biopsy, and it is not needed nowadays for diagnosis of acute fatty liver of pregnancy because it carries risk of complications. Okay, so it is rarely utilized today. Let us go to Swansea criteria to reach the diagnosis of acute fatty liver of pregnancy. If we found 6 criteria from clinical features, from lab features, from ultrasound feature, from histologic feature, all of them 6, so diagnosis of acute fatty liver of pregnancy is reached. So what is the criteria? From clinical features, nausea and vomiting, abdominal pain, encephalopathy, polyuria and polydipsia. From lab features, hypoglycemia, blood glucose less than 72 milligram deciliter, bilirubin more than 0.8 milligram deciliter, white BCs more than 11,000, liver enzyme AST or ALT more than 42 units per liter, acute kidney injury or creatinine more than 1.7 milligram deciliter, coagulopathy or prothrombin time more than 14 seconds, ammonia more than 47 micromole per liter, urate more than 340 micromole per liter. This is as regards the lab feature. The ultrasound feature, including ascites or echogenic liver or fatty infiltration. Okay. What about histologic feature? Microvesicular steatosis or liver biopsy. Okay. Then I'm collecting what is present in the patient from all these criteria. If I reach it 6 or more, so acute fatty liver of pregnancy is diagnosed. This is as regards the Swansea criteria. What is the differential diagnosis of acute fatty liver of pregnancy? As I said before, it is challenging to differentiate acute fatty liver of pregnancy from HELLP syndrome. All of us know HELLP syndrome and severe preeclampsia. Okay? There is significant overlap between these disease entities, and in fact, they may coexist in the same patient. And she is of bad luck, this patient that carry post complications. But you should know that elevated liver enzymes, coagulopathy, hypoglycemia, and the hyperbilirubinemia are more severe in acute fatty liver of pregnancy. Okay? What else in differential diagnosis? Of course, differential diagnosis from other causes of liver disorder during pregnancy, like viral hepatitis, like drug-induced, like autoimmune hepatitis, like intrahepatic cholestasis, like all of these, or liver disorder during pregnancy, you should rule out before reaching your diagnosis. Okay? Complications of acute fatty liver of pregnancy can precipitate pulmonary edema due to decrease in plasma oncotic pressure. We have hypoalbuminemia and decrease in plasma oncotic pressure. Liver failure can be associated with pancreatitis, DIC, metabolic acidosis leading to maternal or fetal deterioration that can cause fetal death and also maternal mortality. Okay, here we are in treatment. This is an obstetric emergency. Please remember that. We should do support to the mother and delivery of the fetus. This is an important and an emergency situation, okay? So, supportive maternal care and the prompt delivery are important for achieving full recovery for the mother. Somebody may say the baby is still premature. You should terminate pregnancy regardless of the gestational age, but after resuscitation of the mother. Do resuscitation for the mother and do termination of pregnancy by vaginal or cesarean section, but cesarean section is more common. Remember that this obstetric complication, acute fatty liver of pregnancy, needs multidisciplinary care by obstetrician, anesthesiologist, intensivist, hepatologist, and the pediatrician. Start with resuscitation to the mother immediately on admission to the hospital. Supportive maternal care and the stabilization should be initiated first with correction of electrolyte disturbance and therapy for coagulopathy. You may do platelet transfusion, fresh frost plasma transfusion. Hypoglycemia should be corrected. Fluid replacement should take place if needed. Also, fetal monitoring, continuous monitoring of the fetal heart rate is important. Then prompt delivery, hurry up in delivery, regardless of the gestational age, and the cesarean delivery is usually the preferred mode of delivery, although it carry risk due to complications like coagulopathy and so on. But is vaginal delivery is not indicated? No. Vaginal delivery, you can do it. But if the situation is suitable for vaginal delivery, okay? So, vaginal delivery and the liver induction can be done if no contraindication exists. However, cesarean delivery has to be performed in many cases due to maternal or fetal distress and deterioration. So, why cesarean section is more common? Because of maternal and or fetal distress. This is why cesarean section is common. But if there is no this indication, we can do induction of labor and vaginal delivery. Okay? But remember that if you are going to do cesarean delivery, platelet transfusion may be necessary as current guidelines recommend transfusion to a level greater than 50,000 per minute. Okay? So, of course, platelet transfusion is important before doing this cesarean and during the operation. What about anesthesia? Local, spinal, epidural, or general anesthesia? According to the situation, I may need spinal or epidural anesthesia if platelet count more than 70,000 and there is mild coagulopathy. You can give the chance for neuroaxial anesthesia. Okay? But in more severe cases, general anesthesia may be more suitable. Why? General endotracheal anesthesia may be necessary for maternal airway protection. This is one. Second, profound coagulopathy prohibiting regional anesthesia. I can't do regional anesthesia like spinal epidural because of severe coagulopathy. Severe coagulopathy is contraindicating to do regional anesthesia. Also, fetal decompensation. Fetal decompensation severely, the fetus is severely distressed. So I need an emergency cesarean delivery, and the emergency cesarean delivery occur need a general anesthesia, not spinal or epidural anesthesia. It takes time. So what will save time is general anesthesia in case of emergency acute fetal distress. The baby is dying, so you should save life of the baby. Okay. So according to the situation, go to either general anesthesia or neuroaxial anesthesia. Neuroaxial anesthesia or general anesthesia. Okay, if the baby is too premature before 32 weeks gestational age, it is better to give the mother magnesium sulfate because it was found that magnesium sulfate could be protective and prevent neonatal cerebral palsy. Okay? After delivery, the mother should be admitted to the ICU. Intensive supportive care should be given, and the close monitoring for bleeding, hypoglycemia, encephalopathy, and renal dysfunction. And as I said before, multidisciplinary team should be involved in management of such case. Sometimes the condition deteriorating, the plasmapheresis was used in certain hospital for acute fatty liver pregnancy complicated by liver failure. Plasmapheresis reported success in these severe cases in few series. However, if hepatic dysfunction doesn't abate rapidly after delivery, liver transplantation should be a considered approach as it may prove life-saving. What about prognosis? Really, the problem with acute fatty liver of pregnancy is the delay in diagnosis. So early diagnosis, you can save the life of the mother and the fetus. So early diagnosis is necessary to ensure better maternal and fetal outcome. In many cases of acute fatty liver of pregnancy, complete resolution and liver function normalization occur within 10 days after delivery or little days more. Okay, so if you diagnose the case early, if you terminate the pregnancy and resuscitate the mother, you are saving the life, and normalization of the liver function may happen after 10 days. Okay, but you should know that maternal mortality rate in the past was 75%. Imagine how big is the problem. But nowadays, for early diagnosis and the early management, it is decreased too much. So maternal mortality nowadays less than 5%. So the key of success with these cases is the early diagnosis and management. And as I said, in two words, resuscitate and do the delivery of the fetus. Okay, resuscitation and the delivery. This is the two words in acute fatty liver of pregnancy management. Okay, what about the delivered baby? Children may be at risk of hypoglycemia, dilated cardiomyopathy, progressive neuromyopathy, and the sudden infant death syndrome. So, the infant and the children should be followed up by pediatrician to be sure that there is no complication. The child of acute fatty liver affected mother should undergo molecular testing for long-chain 3-hydroxyacyl coenzyme A dehydrogenase deficiency, as well as close monitoring for its manifestations, including hypoglycemia and fatty liver. So, in reported cases of acute fatty liver of pregnancy, remember that the children should be observed by pediatrician, and this child should undergo molecular testing for long-chain 3-hydroxyacyl coenzyme A dehydrogenase deficiency, as well as close monitoring for its manifestations. What is the manifestations? I should look for hypoglycemia and fatty liver. This is the end of my lecture. I hope it is clear enough. Thank you, everybody. This is my book, Textbook of Obstetrics, Textbook of Gynecology, Contraception Handbook, and the Multiple Choice Question Book, published on Amazon. And this is my site on Amazon and my site on YouTube and my site on Blogspot. Best wishes for all of you.